My name is Joshua Royce. I'm a thoracic medical oncologist at Georgetown Lombardi Comprehensive Cancer Center in Washington, D.C. And in this session, I will be discussing frontline combination immune checkpoint blockade in treatment-naive advanced malignant pleural mesothelioma. This should be primarily a review based off of other sessions in this module, but to recap, combination chemotherapy with cisplatin plus pemetrexed has been the standard of care for advanced malignant pleural mesothelioma since its approval in 2004, with a response rate on the order of 40% and a median survival of about 12 months, as illustrated in the figure on the right side of this slide. Unfortunately, therapeutic innovation to this approach has been disappointing. Bevacizumab, an anti-VEGF monoclonal antibody, provides about 2 months absolute overall survival benefit when combined with cisplatin plus pemetrexed in the frontline setting. However, combination PD-1 and CTLA-4 pathway blockade has demonstrated encouraging results in single-arm phase 2 studies of platinum-refractory advanced mesothelioma, as I now show on the right side of this slide. This is a slide I previously showed in a prior module of the MAPS-2 study, a randomized non-comparative study of Nivolumab with Ipilimumab and Nivolumab monotherapy that shows encouraging survival results for the combination. So with that as a backdrop, let's present the phase 3 CheckMate 743 trial. This trial was a randomized multi-center international phase 3 study that evaluated patients with unresectable pleural mesothelioma that was treatment-naive and randomized patients to Nivolumab plus Ipilimumab or Platinum-Pemetrexed chemotherapy. Patients were stratified by tissue histology and gender, and the primary endpoint was overall survival. CheckMate 743 was a positive study, with Nivolumab plus Ipilimumab demonstrating improved survival compared to Platinum-Pemetrexed chemotherapy in treatment-naive advanced malignant pleural mesothelioma, with a median overall survival of 18.1 months with Nivolumab plus Ipilimumab compared to 14.1 months with chemotherapy, with a hazard ratio of 0.74. And based off of these results, in October, the FDA approved Nivolumab plus Ipilimumab in the frontline treatment of advanced malignant pleural mesothelioma, the first drug approval in mesothelioma in over 15 years. Let's take a deeper dive at these results. As you can see here, overall survival benefit was most pronounced in mesothelioma patients with non-epithelioid histology, while the median survival achieved with combination checkpoint blockade was similar in those with epithelioid and non-epithelioid histology, with very similar survival curves. You can see that for patients with non-epithelioid histology, the magnitude of improved survival was most pronounced. This makes sense given that this is a histology that is traditionally chemorefractory, and so it makes sense that those with non-epithelioid histology would see a significant benefit from Nivolumab plus Ipilimumab compared to chemotherapy. Here are subgroup analyses from CheckMate 743, and I'd like to draw your attention in particular to the PDL1 analysis. And based off of this, one might be tempted to suggest that PDL1 may serve as a predictive biomarker in mesothelioma. However, I would caution against this conclusion. For one, patients were not stratified by PDL1 status in this study, and also non-epithelioid histology traditionally has higher PDL1 expression, so there are multiple confounding variables, and we cannot yet determine if PDL1 is a predictive biomarker in mesothelioma. Secondary analyses from this study. So as you can see here, Nivolumab plus Ipilimumab achieved similar response rates compared to chemotherapy with similar rates of disease control. However, the duration of response was greater with Nivolumab plus Ipilimumab, with a median duration of 11 months compared to 6.7 months with chemotherapy. And as you can see here, nearly a third of patients had ongoing response at 2 years out from therapy with Nivolumab plus Ipilimumab compared to 8% from therapy initiation with chemotherapy. Moving on to adverse events, you can see that there were a similar rate of adverse events with both regimens. However, the specific type of observed adverse events varied, which makes sense given the varying mechanisms of these therapies. For patients treated with Nivolumab plus Ipilimumab, diarrhea, pruritus, skin rash were more common, compared to those treated with chemotherapy, where nausea, cytopenias, fatigue, decreased appetite, and asthenia were more common. Specifically looking at immune-mediated adverse events, we see a similar pattern and distribution of immune-mediated adverse events that we have come to expect with Nivolumab plus Ipilimumab from trials in other tumor types. You can see that the majority of immune-mediated adverse events were of low grade and the majority did improve with immune-modulating medication. However, it is important to point out that for patients who develop grade 3 or higher immune-mediated adverse events, these patients often require prolonged steroid tapers and potentially additional immune-modulating medications, and it is important to discuss this when considering this therapy for patients. For additional information on the management of immune-mediated adverse events, I encourage you to review guidelines from the NCCN and other societies such as ASCO and SITC. In conclusion, CheckMate 743 demonstrated a statistically significant improvement in overall survival for Nivolumab plus Ipilimumab versus Platinum-Pemetrexed chemotherapy in treatment-naive advanced malignant pleural mesothelioma, and is the first drug approval in the frontline treatment of mesothelioma in 16 years. The magnitude of observed benefit was greatest for those with non-epithelioid histology, and in my opinion, Nivolumab plus Ipilimumab should replace Platinum-Pemetrexed chemotherapy as the frontline standard for these patients. The picture is less clear for those with pure epithelioid mesothelioma, where the magnitude of benefit was less pronounced, suggesting there remains a role for chemotherapy in the treatment of this histologic subtype. I'm not saying that these patients shouldn't be treated with combination immunotherapy. We do know that immunotherapy works best in the frontline setting in multiple tumor types. However, results of phase 3 chemoimmunotherapy trials will be important to weigh the relative risks and benefits of a chemoimmunotherapy approach compared to combination immunotherapy in these patients. Lastly, while it may be tempting to suggest that PD-L1 has a potential predictive role as a biomarker in mesothelioma, since CheckMate 743 did not stratify by PD-L1 status, and there is a higher PD-L1 expression in patients with non-epithelioid histology, those that benefited the most in this study, one cannot ascertain the role of PD-L1 as a predictive biomarker in mesothelioma based off results from this trial. That concludes this session, and I thank you for your attention.